So, as we wrap up this session, I want to extend my heartfelt thanks to everyone for your engagement and insightful discussions. It has been a wonderful opportunity to deliver this important topic in the public health. I am now pleased to introduce our next moderator for the next section, Dr. Muhammad Al-Hafdi. Dr. Muhammad Al-Hafdi, he is a consultant physician in preventive medicine and with expertise in health and clinical informatics with a wealth of knowledge and experience in this field. We are excited to have him as guide us through the next session. Please join us for welcoming Dr. Muhammad Hafti to this stage. Dr. Muhammad, the mic is yours.
Yes. Thank you so much, and thank you for the opportunity and interesting talks actually across this long-awaited conference. It has been my great pleasure to be part of it yearly. I look forward to it really eagerly. And definitely today I've learned a lot from many colleagues, teachers that I will always be proud to be learning from and continue to learn from. So we'll move to the next session to talk more of applications, things that are related to really meet the theme of this conference when it comes to applications for AI in the public health domain. And to start with a very dear expert in that field, Dr. Ahmed Abu Salah. I've always really wanted to work with Dr. Ahmed in many endeavors. Hopefully, inshallah, the time will come to cross the path and learn from his expertise. Dr. Ahmed is a healthcare informatics and intelligence officer, director of the Center for Healthcare Intelligence at King Faisal Specialist Hospital and Research Center. And he's also an affiliate biomedical informatics professor at the University of Minnesota. Dr. Ahmed is going to cover the topic of AI in healthcare and lessons learned from his experience. So please join me to welcome Dr. Ahmed in his.
Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Ahmed Abu Salah. I am the director of the Healthcare Center at King Faisal Specialist Hospital and Research Center. I'm also affiliate professor at Al Faisal University and the University of Minnesota. To just quick intro about myself. Prior to joining King Faisal, I joined King Faisal in 2019. Prior to that, I was a professor and director of clinical informatics at the University of Minnesota, where we also established the clinical informatics and data science core in the university, working also in translational research. I would like initially to thank Virtual Medical Academy for having me and giving me the opportunity to share our experience with applied artificial intelligence in healthcare. So we're going to go through the journey of applied healthcare AI in King Faisal Hospital and share what we have actually learned as what works and what doesn't work, the failures and successes and challenges. So hopefully I'll have 25 minutes and I put the timer for myself. And let me start actually by apologizing that I couldn't make it really with you live online just because of another event that was that popped up just earlier in the same day, and I felt that I was at risk of missing this one, so I decided I will record it. And here are my information, my emails, my work email and my personal email and my LinkedIn profile. Note that if you email me to my work email through Gmail or Hotmail, etc., it might be blocked by cybersecurity. So if I don't reply to your email, please reach out to me through my personal or through LinkedIn. With that disclosure, I don't have any financial interest or commercial. This is basically my views and our personal experience at King Faisal Specialist Hospital. So let me start actually generic slide about like AI in healthcare, and here it's generic like for me generic like I would say like insights, but I apply to King Faisal Specialist Hospital. How are the clinical and operational decisions are being made? King Faisal, and you can actually generalize this to other hospitals. Clinicians, managers, leaders, they all need to think about multiple dimensions, multiple perspectives before they make a decision, whether operational or clinical perspective. For example, before you prescribe a medication to a patient, you need to know whether you have that medication or not. Before you schedule an OR, a surgery, etc., you need to know whether you have supplies for that procedure or not. Otherwise, you're going to end up in cancellations. And cancellations, and that actually will end up with losing underutilization of OR rooms that have been booked but not utilized, and basically a patient who is not satisfied at all because his OR got his surgery got rescheduled after being prepped. So supply chain management, you have to think about all of this. You need to think about whether we're going to have medication supply, etc. Even 2 weeks, 3 weeks, 1 month from now, you need to think about that before you make any decision. Another thing you have to think about the patient. Patients today, today's patient is different than the patient from previous generations. Today patient, he expects actually to come to the hospital only for serious cases. They're not going to waste a full day just for a 5-minute appointment that tell them, well, we have read your results, you're good, you don't need, thank you so much for wasting your day and staying in 2 hours in waiting room to meet the doctor for 2 minutes or 5 minutes and leave. And he took already like 1 day off from work and from the family just to stay in the waiting room. So the expectations are very different. And nowadays, patient satisfaction is a crucial thing everywhere you go. You have complicated cases, you have clinical guidelines limitations that you need to think about. Like, now, most of the cases, you have like doctors, they review patient cases in panels. So you have like all the boards. So they review actually all these patient cases, and they would love to have some handy tools that will tell them what happened to patient Ahmed when he was like 2 years, when we gave him certain medication or treatment plan, because now we are evaluating a similar patient case and would love to compare it to historical patients that we have seen in the past and see the outcomes of various cases. We have operational goals. Operational goals like KPIs, like now everyone in the organization, they're looking after KPIs, whether it's from financial perspective or from accreditation perspective or from operational cost, etc., etc. All these like must be considered, especially revenue generation also become a crucial factor in addition to the clinical outcome of any organization. Think about also like the patient flow analysis. Patient flow analysis, we need to know actually the patient, the full patient journey in that clinic. These patient journeys will lead to the ultimate goals of the organization. And on top, I put there subjectivity. Subjectivity is basically like an organization, large organization like King Faisal. You have more than 16,000 or 17,000 employees. Many of the clinicians have been trained in various schools, whether US, UK, Saudi Arabia, Singapore, etc., and they all come with their own education experience and training, and each one of them have his own probably or some differences between the treatment plan that they recommend. So think about all of that, and what is the core? What is common among all of them? Data. All of them, they look for data, for guidelines, for patient historical data to make decisions. So it is actually a complicated process and will require access to data, access to the right data, in the right format, and in the right time. And let's see actually how it's being decisions today, clinical decisions are being made. It's being made using EPM, evidence-based medicine. So and until now, if the doctor makes a mistake, they will look into the evidence-based medicine and say, okay, have you followed the guidelines? Have you followed the protocol, etc.? And that's how they decide whether it's wrong, right, or wrong. But look at the EPM, evidence-based medicine. had been like doubled, almost like doubled within 73 days by 2020, which already passed. So I think like now the medical knowledge have doubled, maybe in less than that, almost 2 months. You have, and doctors, they don't have protected time just to go and every day you will have 20%, 30% of your time dedicated to reviewing the literature and identifying the latest and the greatest in your field. This like in one, so it's the clinical knowledge is moving at a very fast pace. The other domain that's also moving at a very, very fast pace is technology. And think about like what happened in the last 20 years. In the last 20 years, all organizations, healthcare organizations, have been focusing on building their digital infrastructures. EMR, building EMR system, electronic medical record, storing patient data in a digital format. So within the last 10 to 20 years, that was the main discussion. And now in the last couple of years, what happened is that organizations realized that, you know what, we have enough digital data. We need to use this data. How can we use it? And that's why you feel like now the AI technology came to mind. The biostatistics is a core component. Data science, ML, AI, etc. All of them came back now to say that, you know what, we can solve some of the most challenging problems in healthcare using the data that have been captured and collected over the last 20 years or more. So, so what we are doing here is we are merging two of the very fastest growing fields at this time, which is the clinical discoveries and emerging technologies. What we learn today about technology in 2 years is going to be like just like old technology. Think about generative AI and GPTs. 2 years ago, no one was talking about it. Now it became a crucial project in almost most organizations that we must have secure, safe, compliant, accurate GPT applications to enhance the clinician's experience. So at the King Faisal Specialist Hospital, we built the established Center of Healthcare Intelligence. It's a value-driven, goal-oriented. And here the goal is not, the ultimate goal is not research application. Research application is secondary goal. The primary goal is we build an applied artificial intelligence application for addressing the ultimate goals of the organization. Satisfaction, enhance satisfaction for all stakeholders, not just patients. We're talking about enhancing clinician satisfaction, and most of the time, actually, when you enhance clinician experience, automatically the care quality or the quality of the care that being delivered to the patient will enhance. Then sustainability, we're talking about actually enhancing financial sustainability of the organization, technical sustainability, and human sustainability. And it's not always feasible just like to buy AI solutions and deploy it in the organization. You need to build your own because it's going to be expensive to maintain it. The third dimension as well is the competitive advantage and thought leadership. So we have ultimate goal, satisfaction, sustainability, and competitive advantage or thought leadership. We need to promote your organization as a thought leader in healthcare AI, and that will help you with a lot of things like number one, recognitions, awards, visibility, grants, partnerships, and establishing strategic partnerships with various organizations, whether we're talking about vendors, health tech vendors, or universities or hospitals globally. So it's crucial that we have this in mind when we build any AI application or acquire an AI application. The center here, having these goals in mind, we decide like the center will build the projects that are applied and will have immediate impact, and it's driven by an actual need of the organization. And you have in mind that these ultimate goals that we spoke about. That's actually before you start any project. And in healthcare AI, this needs to be captured, whether it's applied or just for research purpose. Does it have an impact, and does it really address a need in the organization, and how can we link it to one of the strategic goals of the organization related to satisfaction, sustainability, and competitive advantage. And there's like the operational model that we'll talk about it shortly. So let me start actually. Now the question is, okay, we usually, when we ever start a project, the question is, where is the value of this healthcare AI? It's nice, it's wow, We always have a great idea. I would like to use AI for enhancing healthcare, but where is the actual value here? Many times we receive requests that I want to use AI to treat a patient. So they want to focus on a clinical decision support. Well, as this lady actually said, is actually I don't want AI to do the stuff that I'm good at. I want the AI to take care of the noise around me, take care of my dishes and take care of my laundry so I can do the stuff that I'm good at. And that's what the clinicians have been trained to treat patients for many years, and they are so good in this. But just to remove that noise around them. What is the noise around them? How to deal with systems, digital systems. And that's actually a big problem that now we're trying actually to focus on in King Faisal Hospital. And this one. Number two is how can I read all this data quickly and just get to the right information in the right format quickly so I can make my decisions. So we build now the governance. In the purpose of time, I'm just going to try to speed up my slide. So the governance, when you start actually building an AI application in the organization, we need to focus, number one, on the value, approved business case. What is the quantified value, and what is the actual impact, and what is the need that we're trying to address? Has this work has been done before? Should we just leverage some open source code? If it is there and it's and the license allow me to use it, I'll use it. If I can just tune something that has been validated and tested somewhere else in other hospitals, do it, because that will save you a lot of time instead of starting from scratch. Do not start from scratch. Wherever people do not start from scratch, it takes a lot of time. And the most time consuming step is data collection and cleaning and preparation and engineering. That's a very time consuming step. And then you build a model. After you build a model, you test it internally in your AI team. Another developer will test the model, and then you ask an external AI expert. Most likely, in our case, we try to consult professors in universities, whether national or international, to be reviewers with us. They review and tell us, you know what, you missed X, you missed Y, you overlooked this. Because simply you cannot be the one who tested and the one who built it and you say it's good. So you need external eye. And then you send it to the clinicians or the leader or the manager to end user, basically, to validate it. And keep it there for a couple of months until you both teams and all stakeholders reach to a agreement that, you know what, it's good, let's deploy it. And then you work on the workflow integration and deployment. And keep this at the end. Do not get into the deployment and workflow integration until the system is fully tested and validated by all parties. Now, after it has been live for a few months, you go after knowledge sharing, thought leadership, awards, recognition, conferences, etc. Of course, you will have a feedback loop, and this is crucial to have it fully automated pipeline to track all your AI models you have deployed in the hospital. Just simply because maintaining AI model is expensive, and you don't want to maintain it if it is not adding value, or over time it has some bias or some change in performance, etc. So that's a crucial feedback loop. But the feedback loop is another point. The feedback loop should not be he should not be fully in the feedback information automated to basically give it the opportunity to adjust the model performance or the model performance automatically. You want to capture all the feedback and then do your own manual analysis on that automated feedback that you captured and you categorized and you cleansed, etc. And then build your AI model version 2 and then do the same testing and validation again and then deploy it. You don't want the system to take the feedback from end users automatically and put it, just because simply the feedback is not fully trusted. Again, you will have clinicians who have different opinions or different patient cases. So you will have your clinical team who's assigned this project evaluate the feedback and decide which ones that are correct and which ones are not correct. Now, responsible AI. Responsible AI is a huge topic by itself, but this is crucial to implement. And maybe there's a lot of ideas here, but I would highly recommend that you consult DGA, District Government Authority, SADAYA, and other organizations. Now we have in the country, we have several great models, I would say, and criteria that you can easily monitor and put it as part of your AI evaluation process. And this you can apply for the one that you built in-house or the use cases that you acquire from you purchase from vendors. So using this approach, we deployed so far in the hospital 15 AI applications developed in-house and deployed. And here I captured only the ones that we developed in-house. We have other AI models that have been purchased through vendors. Maybe the first one I would say is the COVID-19 system. This was the first one when I arrived to the kingdom. It's like and was like, I think that changed everything. I remember before COVID-19, we used really to go for doctors, please let's work on an AI project. It does add value, etc. And there wasn't really this huge interest. And then COVID came, and we built a system that will predict the volume of patients, predict the supplies, the services, the rooms, the infected staff, etc. And we linked all of this into one nice visual analytics like platform, and it was the one used during the crisis. And after that, things got changed, and everyone started actually submitting requests for AI projects. We built a system for patient satisfaction. Now it's been live for 3 years now. Predict the patient experience in some oncology treatment units prior to their visit, 3 days prior to their visit, and link the prediction to an action. So we say that this patient who's coming like in 3 days most likely will have a negative experience because of dimension 1, 2, 3, 4, 5. And for dimension 1, you need to do X in order to fix his future experience. And for dimension 2, do action 1 in order to fix or basically enhance his future appointment experience. And these dimensions came from Priscani satisfaction survey. So we took Priscani satisfaction surveys, the historical one, linked to the patient charts, and came up with the model for. And this one, actually, the impact, we were among the in the global benchmark, or the benchmark that Priscani does globally for all hospitals. We were among the top 16th percentile globally. Now we are top 6th percentile globally. Then we have some biostatistics or classical data analytics, like the readmission rate, 30 readmission rate, and length of stay. Another thing that I can highlight here is, while these are actually really classical models that have been developed in most research papers, the missing component here is the action part. So when you build like a 30-day readmission model, say like, okay, this patient is a high risk of being readmitted within 30 days, link that to actions. If there's no action, do not build it, because no one will actually make, there will be no impact. So if I know, if you tell the doctor this patient will be like readmitted within 30 days, what are you going to do? If he tells you, yes, if I know I'm going to do 1, 2, 3, I'm going to give him whatever medication at home, I'm going to do something, then we have specific action, then yes, now your AI will be impactful. And the same thing for length of stay prediction. Then we did medical imaging AI. We built in-house normal chest X-ray detection. Most hospitals, at least 50% of their chest X-rays are normal chest X-rays. So what we identify chest X-rays, we put the chest X-rays lower in the priority of radiologists. So basically, he can assign this to residents, to fellows, to junior doctors. So senior doctor clinicians can focus on the suspicious case, and this is very influential in service and segmentation. Organ segmentation, same thing, like how to segment organs, like identify the liver, the kidney, their sizes, etc., the volume, and make it automatically instead of automated process instead of manual. Lung fibrosis, can you compare lung fibrosis day 10 to day 1 and do that? So all this have been built in a hospital. Rare disease detection, link the dysmorphic features of the facial to the gene disorder. And this is actually a case, although it's rare diseases, but at the same time, you have patients who have been really struggling for years, looking for the right treatment, before someone said, you know what, this patient, when I compared his facial dysmorphic features compared to the atlas, just like in paper-based atlas, I would say he most likely has this genetic disorder, and then the treatment plan has totally different course. Now you can do it like just by your phone and a camera. This one actually has not been deployed yet. We are testing it for more cases in other hospitals. Then we have actually the dimension about generative AI. Generative AI, it's by itself can take actually a lot of time. Generative AI, GPT, focusing on the chart summarization and finding the right information, but we have to do it on premise, and it has to be done. I have to do it on premise, and has to eliminate hallucination and being focused to the knowledge of the hospital, and be sure that the information generated are accurate and complete. All these factors has to be considered. We cannot just like use ChatGPT, or we have to use Llama, Cohere, or whatever you want. Put it on premise. Do your RAG or performance tuning. Each one has its own technique, but think about this. It's not an easy process. Tuning and RAG is crucial in order to eliminate the hallucination, make the answers limited to the knowledge of your hospital, and start with non-clinical use cases I'm going to show in a second. Then we built for operational intelligence. We built a command center for the hospital that will track the patient journey from door to discharge, and the same thing for patient journey. This is all built in-house. For the Gen AI, as I mentioned, we built something called Johanna that is linked to all the policies in the hospital. So patient now we can ask, what is the process for, not patient, sorry, staff can ask, what is the process for enhancing, for onboarding new employee? What is the process, how can I submit professional leave? What is so all this kind of question that usually relevant to are in the policies and no one likes to read. So we summarized for the end user, and we put a link to reference in that, and that's like now easy. Then, as I mentioned, we monitor the whole. We build an application platform in hospital to monitor the whole journey of the AI performance, basically. Sorry, measure all the performance metrics of the AI models, and that's from technical perspective. And we have the command center. They are specialized administrators and operational managers of the hospital who track the outcome from business value. So if they tell us that, you know what, your AI model is good, and technically the accuracy is high, very high accuracy, but at the same time it's not delivering business value, then we stop that project. Then we focus on building the human capacity. So we build certification courses, and this is crucial, very crucial, to train your resources on the AI, train your resources on the applied healthcare AI. Because if you have clinicians or managers or leaders who are not really fully linked to what you are doing, then they will definitely either underestimate or have very high expectations from the AI. So you have to build your own certification courses and training to build that. Then we work after recognitions. We achieve like high. We get like HIMSS Analytics Stage 7, the most advanced data analytics, and other awards. Our healthcare AI certification course achieved like the هيئة التخصصات السعودية Professional Course Excellence Award, etc. In ZIMAM and HIMSS also we get the AI Center of the Year in 2024 DCC area. We work through collaborations, because simply you cannot build a whole team in one organization for just dedicated to AI. You need to have scalable human capacity through collaborations with various national and international entities. My last slide here, also always remember like the key points to consider. Number one, domain expert engagement in healthcare. It's very challenging to get clinicians to participate in building AI, just simply because they don't have protected time. But at the same time, we need their domain knowledge. So that's the kind of challenge that you would keep in mind. And other concern, generalization. Until now, we see that actually cases where a staff, a leader, a clinician, etc., they attend a conference, they saw a model, I want to put that model that works in hospital X, I want to put it in our hospital. Well, a lot of models actually they do not generalize easily, and you will end up actually building another application. So this is something that you need to try to consider when you discuss with the end user. Maintenance of AI applications is not simple, so it requires always a quick review, and it requires a kind of maintenance. So you need to be sure actually that you have the time and budget to maintain this. The impact and sustainability and leverage startups. Now there's a flood of startups, nationally, internationally. Yes, get use them to that. They look for you to enhance their product, and you look for them to save you time and effort. So that can be a win-win for both parties. With that, I think like I'm 2 minutes, sorry, 2 minutes like behind my time. This is my contact information. Please reach out with any questions or comments you have. Thank you again, Virtual Medical Academy, and thank you all for being with me. Wassalamu alaikum wa rahmatullahi wa barakatuh.